Cancer care is taking a full circle restructure at the moment, and the research is coming out at the moment that actually moving more is more beneficial in the treatment of cancer and the treatment of treatments for cancer. So we're a program that's enhancing the recovery by getting people to move more.
And basically one of the things that we've discovered is that the physical activity specialists who are encouraging this, and they're a foundation stone of the programme that we do, working with cancer patients, actually need psychological skills to be able to make that happen. So that's basically where I come in, is developing a series of workshops on developing those skills.
It really works twofold as well, purely because we're educating healthcare professionals but also educating the patients. It wasn't that long ago that as healthcare professionals we were telling people to rest, and rest is best, whereas now we're re-educating the healthcare professional teams and saying that actually by moving in an individualised, almost prescribed programme is much better.
So we bring people into the programme, and most of them, after a holistic needs assessment, go into a 12-week exercise programme, which is, if you like, an introduction to exercise based on their previous background. So it works for people who were running marathons but can't do that any longer, and people who were couch potatoes. And we now want to encourage to live more actively to improve their well-being and reduce their risk of cancer recurring.
The Berkshire Cancer Rehabilitation Programme is based on a wellness ethos. We look at 4 arms really: education, social support, physical activity and psychological skills. Everything we do is based around holistic needs assessment for the patient in a community setting. It's really important that we try and join up community care, primary care and the acute trust, from getting people at diagnosis right through to end of life and within palliative care. And we see people from diagnosis, during treatment, post-treatment and at end of life within those 4 arms, within a multidisciplinary team.
And so one of the things that we do is pick up these things, that end of cancer treatment moment, for example, where people suddenly get their hair back, start to be a little bit more active, go back to work. Everybody around them breathes a huge sigh of relief, stops bringing around the casserole, stops checking up on them, stops being the supportive friend. And that can actually be the moment where suddenly people find themselves struggling at the greatest extent that they ever have through this journey through cancer or pathway, or whatever you want to call it. And when we pick them up at that moment and do a holistic needs assessment and figure out what's going on, sometimes that in its own right is an incredible moment of relief and can really focus, well, how do I move forward from this experience to building a new normal life? What do I do now? I don't feel the way I used to feel 2 years ago, but now I've got a better idea of what to do about it.
And what not a better way to do that in their local leisure centre or in their local community, to give them their normality back, to give them their reality and signpost them to something that's sustainable within their community, mixing with their friends within a safe environment.
So I think one of the things that's really cool is that during their 12 weeks of exercise classes, they'll get signposted to try out various different types of exercise, from walking to walking football to yoga to swimming, so that by the time they've done those 12 weeks, they'll have an idea of actually what works for them now, and actually an idea of what they want to do activity-wise and how they want to build it into their best possible life moving forward after treatment. The aim is, it's about all sorts of a combination of things, some of which are about improving patient experience, making that transition back to normal life the medical system doesn't want to deal with you very often, to living better, to being healthier. And it's just as appropriate to London, Scotland, Yorkshire as it is to Berkshire. We're just very lucky that we're one of the pilot sites to do this sort of thing with.
And we're really proving that at the moment. We work across 3 trusts, 7 CCGs. Within 2 of those CCGs, we have a population of the world. So we can show that within the most rural communities and the most urban communities, within different population groups and demographics, that actually this works within lots of different community aspects. Within the other aspects that we're looking at within physical activity, it's about the understanding of how the community care arm can come into the acute trust and how we can expand their knowledge a little bit more. We actually sit down with the patient for an hour. We have a clinical nurse specialist and a physical activity specialist who will triage a patient. We've had 1,000 people come through our system at the moment, and we've had 14% of them not interact with our services whatsoever. And that's for many different reasons. That might be transport issues, death, or they're just getting back on with life and they don't need our services at that present moment. So the choice of which program they choose within that whole directory of services is a care plan built by the patient themselves. So we give them everything that we have and the understanding of different aspects of the program, but the patient will decide ultimately within their self-management program what they want to do within that program. And I think that's what it comes down to. We, as healthcare professionals, are very good at saying to people, self-management, patient choice, as long as it's one of these three things. We don't do that within the wellbeing program. We ask the patient what they need, and then we come together as an MDT and discuss if we can't find the answers.
So we can generally find somebody. If we haven't got the answers, we can generally, we've done a lot of research into what services we can access, and we can generally, if we haven't got the answer, we generally know somebody who has from that point of view. But the basic plan is that everybody at the end of treatment gets what's effectively an appointment card that says your next program, your next appointment is with the Berkshire Cancer Rehab program. Here's how to make it. And then they will, ideally, most of them should then get in touch with the programme and go through that assessment process and come out with, you're fine, carry on, nice to see you, you know where we are if you need us, or a tailored programme based around physical activity or relationship, work on relationships or help back to work or whatever it is that they actually need at that stage.
Our biggest referrer as well are clinical nurse specialists. So the acute trust bring out their patients into the community. So we're very much part of the CNS group. We sit on their fortnightly meetings within the acute trust, but we also sit on the health and wellbeing board within the community as well. And as Margaret was saying, that we're actually turning things a little bit and making it a little bit more medical on the referral aspect, and oncologists, surgeons are also referring into the programme. And that will then filter through to the GPs as well. But actually the recovery package that we're using could be used within other long-term conditions. There is no reason why the psychological skills training that we're giving for physical activity specialists, for instance, couldn't be rolled out within diabetes or rolled out within heart failure as well. It's a proven model that could be used elsewhere.
And I think it's also, as well as other long-term conditions, it's actually appropriate to the full set of allied health professions. So this will work and develop and improve the effectiveness of occupational therapists, physiotherapists, radiographers is a really important one to get these skills into. And actually at the same time, what that does in a stepped care model is actually save money. I'm quite expensive sitting as a qualified psychologist, so the people that I get to see have been distressed for a while and are acutely distressed and difficult to sort out. If I can push those psychological skills down to the people who are working with cancer patients anyway, then actually it's a brilliant filter in A, heading off a lot of that more complicated distress, and B, using my time more effectively, so that it's only the people who really need the full remit of psychology who come into my office and deal with me as well. I think looking further forward, it's a combination of that, and we're very lucky. We've been funded to pilot something that is basically gold standard. But I think one of the next stages is to look at, well, okay, what are the good enough? What are the really effective bits of this? What are the most cost-effective ways of delivering the most important part of this programme? So that where you've got budget restrictions and you haven't got sort of pilot project type funding, what can you do if you haven't got the sort of special funding that we're lucky enough to have at the moment?
And that could be rolled out to volunteers as well, so we can actually tailor it down. So we're talking CNSs, AHPs, physical activity specialists in the community, but there are also thousands of Macmillan volunteers out there as well. So could we tailor this programme to them? So it means that on the 4-tier programme that Margaret was talking about, that level 4, the clinical psychology aspect, can be freed up for those patients that need them in a timely manner, and then everybody else can be seen at a lower level by the generalists that have been trained up by the specialists.